So today we're going to talk about a lot of information, and most of it is based on the general care of the pediatric population. For instance, communication, physical assessment, interventions that you tailor to the pediatric population, hospitalization, some sensory and communication disorders, cognitive disorders, things like that. So the first thing we're going to talk about as far as communicating, remember, we always talk about the client because it's not just about the patient in your bed, it's about that family as well. And this is definitely true even more so than it is in adults, because you're always going to have with a child a parent attached to them. So that parent is just as much a part of that client as that child is. So when we're communicating with parents, making sure that you encourage them to talk, but direct their focus as well. We often, and I've done this myself as a parent, you get on these tangents that aren't necessarily pertinent to what's going on at the time. So you have to kind of reel them in. You want to use all those therapeutic communication techniques that you learned way back in fundamentals. And a big part of that is providing anticipatory guidance. And when we get to chronic illness in a couple chapters, we'll talk about how anticipatory guidance is a big effect of how parents can deal with the anxiety, especially of chronic illness. Remember, if you are communicating through an interpreter, go back and review those. If you don't remember how to communicate with an interpreter, one of the biggest important pieces of this is if you have a non-English speaking patient, you must use a medically trained interpreter. You should not be using family members. You should not be using staff that speak that language. It should be through a medically trained interpreter. And when you're in a large hospital setting, that's easy. Pretty much every hospital nowadays is going to have some kind of language line device or some kind of interpreter service. But when you're in a smaller place, like for instance at KidMed where I worked at, we didn't have those devices. So we hoped there was somebody working that spoke the language, and if we didn't, we had to often use somebody in the family, like sometimes it was an older sibling that was providing that translation. And you can see the difficulties that there would be with that when you have somebody who's 10 or 11 or 12 years old who is trying to interpret medical information and how that information can get misconstrued or lost. So you really need to use a medically trained interpreter. So when you're communicating with children, a couple of the big important things related to all ages is one, to be honest. This goes with all of them. Children know when you're trying to pull the sheep over their eye or pull the wool over their eyes. They know when you're trying to fool them. I've had lots of parents get mad at me because I tell them that something's going to hurt because I'm giving that anticipatory guidance, and the parents don't want them to know it's going to hurt. The problem with that is if you tell a child something's not going to hurt and then it does, they're never going to trust you again. When in part of those developmental levels, like in infancy, for instance, they're developing that trust versus mistrust. So you can really disrupt that process, even just in a short stay in a hospital, for instance. Another important thing to consider when you're talking about communicating with children is play. Remember, play is the universal language of children. Depending on their level is going to determine how you incorporate that play, but play is the universal language of children. It could be for younger children, getting them to draw a picture. That's also not only a great way for them to have fun, but also you can get a lot out of communicating with them by having them draw a picture. Sometimes in our left brain and our right brain, one side is our cognitive side, one side is our emotional side, and that's why sometimes it's hard for you to put into words your feelings, and it's even harder for children. So maybe even if they can't put it into words what they're feeling, they can draw about it, and you can learn a lot about their what they're going through. So using pictures, even in adolescence, having them write a journal, that's kind of a play type situation. It helps them express their feelings and communicate. Some other things you can do as far as general approaches when you're communicating and approaching children, making sure, especially in your preschool and toddler ages, these are very associated with magical thinking and play. So incorporating their stuffed animals and their dolls or whatever toys they have into that assessment and that communication can greatly help and diminish their anxiety that they have. A lot of how you communicate, and we're going to talk specifically about each level in a minute, is really based on their level of development. So it's going to vary how you communicate with an infant, how you communicate with a toddler, preschool, adolescent, cool age. All of those is going to be a little bit different, but there are some of things that are going to overlap just based on being a child. So when we're talking about a health history, make sure you understand the difference in a health history and a physical assessment. A health history is what you are doing when you're asking the patient information. So you have to ask them, for instance, the review of systems, where you ask them, have you had symptoms this, this, and this? This is everything you're asking them about, versus a health assessment is where you're actually using your senses to collect objective data. So this is where you're listening to their breath sounds, you're watching their respiratory rate. Things like that. You're using those senses to collect that data. So make sure you know the difference in what would fall under a health history and what would fall under a physical assessment. So some things, you've learned how to do a health history. Again, I'm not going to go into this in too much detail. Some of the things we really focus on in children that maybe aren't focused on in adults is immunizations, of course. While even in your adult population, you should be asking about immunizations because they're still important in that population as well. We definitely make even more of an emphasis on it in pediatrics because it can really steer your direction of your differential of what might be going on with the patient, if depending on whether they've had those immunizations or not. Another thing that you're going to see we focus on in peds that you're usually not focused on adults is their growth and development skills. And when you're doing that Denver screening, you'll collect that data. But generally when adults get to adulthood, you're not worried about that growth and development span as much as you are in pediatrics. And it can really make a difference in how you take care of that patient, and also can give you an idea of whether they're meeting those milestones to figure out if they're delayed or if they need some kind of services to help them grow. You're going to look at their habits. When I say habits, I'm talking about their eating habits. For instance, how often do they eat a day? What do they eat? What kind of foods they eat? Their sleep habits. When do they go to bed? How long do they sleep? Even their toileting habits, especially in your toddler age, you need to know about. How often do they have a bowel movement? How often do they urinate? Do they have any problems? You know, those kind of things. If they're having any issues with the psychosocial history, especially in your school age and your teenagers, you need asking about how they're doing in school sometimes. And when we talk about depression and suicide much later on, we'll talk about how in children, a lot of times the obvious signs you think of in adults of depression are not the same as in children. Like in children, sometimes instead of being very sad and depressed like you think of with depression, they may just suddenly have a change in their school performance, or they may start having aggression or have a bad attitude or whatever it be, and that can be those signs. So that can play into that psychosocial history. And then sexual history, you want to be asking about that. And we'll talk about the parameters of ages in just a little bit, but it is best to, obviously you're talking about a teenager, they're almost adults. So this is a more private conversation where you're going to pull them to the side away from their parents to have that conversation. So this is the Denver milestone, the Denver screening, like I mentioned. You've seen this before. You should have done one probably in Lifespan, or at least gone over it if you took developmental psych somewhere else. But it measures that they're meeting, and I will give y'all a copy because I know it's hard to see on here. It measures those milestones. If they're meeting certain milestones based on their chronological age, if they're developmentally appropriate. Make sure you know what 4 areas the Denver screen covers and what you would expect a child based on their developmental level to be able to do at certain stages. So on the Denver screening, it covers 4 areas. Again, it covers language. So it will look at, are they babbling at 6 months? Are they able to put together 2-word sentences at age 2? All those things that are associated with certain ways you should meet those milestones as you progress in your language development. It covers social development. if they have a social smile, for instance, as an infant, those kind of things, and then it progresses on up. And then the other two things it looks at is gross motor skills and fine motor skills. So when we're talking about gross motor skills, those are the skills that require your large muscles to do. So running, jumping, riding a bike, those kinds of things are your gross motor development skills. Your fine motor development skills are ones that use your small muscles or your fine muscles to be able to do. So things like using eating utensils, drawing, coloring, writing, those kind of things are your fine motor skills, and it will give you an idea. And sometimes we'll use an adjusted age, like for babies that are born early, that are NICU babies. Depending on how early they're done, they may have not their exact chronological age, but an adjusted chronological age to show based on if they have been born on time. Yes, they are meeting those milestones, because you expect them to be a little bit delayed just based on how early they were born. They should be meeting the milestones they would meet if they were born on time. Again, this is to make sure where the whole purpose of the Denver, again, is to look at those milestones, because the biggest reason they want to do this is you want to catch those deficiencies early. The earlier you can catch deficiencies, especially when it's not so bad, the earlier you can potentially get treatment and hopefully keep it from progressing much worse. So nutritional assessment, it's not that different from adults in some ways. The ways it kind of differs is how we evaluate their weight and height and if it's appropriate. So in the adult population, we generally use what's called the BMI, the body mass index, and that percentage to determine if their height and their weight are proportional to each other. In pediatrics, we use growth charts, and we're going to get to those growth charts in just a little bit so I can show you pictures of them. But these growth charts are on a bell curve, and they're based on percentage, a percentile of where they should be. And the normal percentile is between 5% and 95%. So outside of those parameters to consider abnormal, a couple other situations that are abnormal would be, for instance, if they have a sudden change in weight, or if their height percentile doesn't match their weight percentile. So for instance, if you have a child who's very overweight, their height percentile may only be 20-25%, but their weight percentile is 70 or 80%. That would be, you don't expect the two numbers to match, but that's a drastic difference in the two. Or for instance, a sudden change, like for instance, when my son went on stimulants a couple of years ago for ADHD, his percentile, he never lost weight, but he gained very minimal weight to the point his percentile in 2 years went from 50 percentile to 12th percentile. And the doctor was very concerned about that. He was still in that 5 to 95%, but that's sudden change, and he wasn't gaining enough weight to maintain on that bell curve of that growth chart. So in your textbook, it talks about nutritional deficiencies and symptoms of those nutritional deficiencies. Make sure you know this, because these are things you need to be looking for in your patients, not just your pediatric patients, but adult patients as well. There's a lot of external data you can collect to give you an idea of those deficiencies, not just from lab. One of the big ones we think of is protein deficiency. You know, in pediatrics, you do see protein deficiencies sometimes. In this country, we don't see it as much. That's that kwashiorkor malnourishment, you know, where they have the big bellies because of that protein deficiency. But you can have other symptoms too that aren't to that degree, like decreased muscle tone, decreased energy. Children usually aren't tired. They're usually running amok. So for a child to be tired and fatigued is definitely a cause for concern. They may have hair loss or very fine brittle hair. They may have brittle nails that break easily. So there are things that you can get an idea of. And again, making sure you're getting that dietary intake. Oftentimes it's very hard to get a dietary intake on a pediatric patient just because of lack of remembering what was eating, or underestimating what was eating, or overestimating, for instance. You want to make sure you're including like what actual foods they're eating, when they have their meal times, how often they eat a day, all those specific information. If you go to the PowerPoint that I posted and you click on this picture, the choosemyplate.gov picture, it will hyperlink you to the Choose My Plate website, And this is a website I highly recommend for everybody to at least get an idea of what it looks like. It's a great resource to use for your patients. You can even go on there and do your own dietary history. You'll put in what you've eaten for the past so many days, and it will break down specific deficiencies that are in your diet and where you need to improve on that. It also has printable resources you can give to your patients. It has everything you can imagine related to nutritional assessment. It's a really good website. So when we're talking about a general approach, this is like your primary approach. Those first things you're pulling in to get an idea of what that patient looks like. So general approaches, we always preach to you about the head-to-toe sequence for adults, right? Well, in pediatrics, we do a head-to-toe, but it's more of a modified head-to-toe. So what's more important in pediatrics than a head-to-toe sequence is a least invasive to most invasive. So instead of, if you start at head to toe, one of the things on the head is the ears. If you do listen to a patient's ears, that's going to make them cry, and you're never going to get those breath sounds. So you do least invasive to most invasive. So your least invasive is any data you can collect just by looking at them. While you're talking to the parent, while you're talking to the child, you can gain a lot of data about their ABCs, about their neurostatus, about how their skin looks, all kinds of things before you've even touched them. And then as you're progressing on, next thing you might do is to listen to them. Listen to their breath sounds, listen to their bowel sounds. That's something that for some patients it doesn't get them as worked up, but one of the very last things you should be doing is looking in their ears, because they don't like it and they are going to start to cry, and you're going to have a very hard time getting the rest of your assessment in. So some other general approaches: let the child touch equipment, and this is within reason. If you are about to start an IV, don't let them touch the needles and play with it. I mean, that's hopefully obvious, but if you're getting ready to do a blood pressure, let them touch the blood pressure machine. Let them, put the blood pressure cuff on their teddy bear. Let them touch that kind of equipment. Let them play with your stethoscope so that it incorporates that comfort zone for them. So this is an example of what ages you do certain things. So a lot of the stuff you see are done throughout the entire lifespan of their childhood. But there are some things that aren't done. Like, for instance, the head circumference is usually only done up to about 2 years old. And the same thing goes for length-based. When you put them on one of the baby scales, instead of having them stand on the scale, that kind of changes. Blood pressures, actually, unless there is some reason to think that child has a blood pressure problem, blood pressures are not routinely done under the age of 3 years. They don't, because it's not significant unless there is a suspected problem. Like, for instance, I had a child who used to come into KidMed with Addison's disease, and Addison's can, if you're in an Addisonian crisis, it can definitely shoot your blood pressure or drop your blood pressure down. So we always had to make sure she was one that was very important to get her blood pressure. So that's where those individual idiosyncrasies may change, but for the most part, we don't do blood pressures under the age of 3. There are certain ages we do certain lab levels, like they always check your lead and your hemoglobin levels at 12 months, because that's kind of when that iron deficiency anemia may start, because you're switching to cow's milk. It also is when they may start showing those signs of the lead screening. And some of those are going to be based on situations. For instance, you see on here that the tuberculin test is listed. Most children don't get a routine tuberculin test unless there is some reason to do it. And then this is an example of the 2007, the most recent recommendation list from the CDC. Yes, you will need to know what ages children get those immunizations. So I recommend that you learn this. There is also resources posted on Blackboard under this week's content to give you better ideas of what those immunizations are, and so on and so forth. Some things that can help you remember these. Remember, no live vaccines are given before 12 months. So your MMR, your varicella, and your hepatitis A are all live vaccines. So they never get those before 12 months. Likewise, when you do maternity, or if you've already done maternity, they don't get those in pregnancy. So if they don't get them in pregnancy, they don't get them in the first 12 months either. Flu vaccine, that's not on here, but usually that will start at age 6 months. You can't get that before the age of 6 months. Oh, it is on here. But they get that every year, just like you would anywhere else, but they get 2 doses that first time they get it to give them an extra boost. Make sure you know this immunization schedule. And then, like I said, the physical assessment or the physical exam, this is where you are actually using your senses to collect data on this patient. Look, listening, feeling, all that stuff. So as far as your growth measurements, you'll use, again, those growth charts. Growth measurements, obtaining those growth measurements is part of a physical assessment. You actually are obtaining that data through your senses. So you'll use those growth charts in comparison to their length if they're under that 2 years, height if you're talking about above that 2 years, and their weight and how it corresponds. Head circumference, again, is usually only up till the age of 2 years, because by then their skull bones have fused together, so their head circumference is not going to be changing at that point. When we're looking at vital signs, we still collect the same vital signs. Again, blood pressure, generally not under the age of 3, but temperature, pulse, respirations, pulse ox, those kinds of things are also collected on pediatrics. As far as checking a temperature, the best method is oral. Obviously, if they can tolerate this, I've had children as young as 2 and 3 years old be able to correctly place that temperature probe. Now, that's not common, but it can happen. But once they can tolerate that temperature probe, generally that's around 4 or 5 years old. Oral is best. If they cannot tolerate the temperature probe, the next best route is going to be dependent on the necessity of accuracy. So if you need an accurate temperature, like they have been running a fever, for instance, rectal is best. If you are doing routine, axillary is best. The scanner type ones where you can scan the forehead, the ear scanners, those are never an option to be an accurate option because they are very finicky. They're reading your skin temperature. So for instance, the ear ones, if that child was, say, laying on that side, that heat has built up in that ear and it may register that they have a fever when they don't, just because the temp right there is warm, that it's measuring against that skin. So oral is best if it's tolerated. If it's not, rectal for accuracy, axillary for routine. As far as obtaining your pulse rates, the best place to obtain a pulse rate in a child over the age of 2 years is your radial pulse, just like an adult. When you're talking about under 2 years old, you use that brachial pulse, which is that midway point of the humeral shaft. When you're doing a blood pressure, selection of the size of the cuff is just as important as it is in adults. If your cuff is too large, it can make their blood pressure look abnormally low. If it is too small, it can make it look abnormally high. If you have to go, and many times children will fall in between 2 sizes, you have to, you're better to have a little bit oversized cuff than undersized cuff if you have to make that choice. Make sure you know your vital sign parameters. They are discussed in your ATI book in that first chapter. Make sure you know those. They vary by age. There's not set ones like there is in adults. So making sure that you're noting those. So then looking at their general appearance, their skin, all these things that you assess just like in the adults. Visual acuity, you can start as early as the age of 4 years old with the Snellen chart. The difference is usually they use the one that has pictures on it. So instead of the letters, it'll have pictures, although I think sometimes those pictures, I can't even figure out what they're trying to draw a picture of. But that can help you get an idea of the visual acuity with the ears. They can start, again, doing what you typically think of as the hearing screening, where you raise your hand when you hear the high pitch. At 4 years old is when they can start doing that, but they have other means of testing hearing before that, which we'll talk about later on. Some things to note when you're doing physical exam is when you see normal abnormalities. And what I mean by that is you will see things in children that ideally they should grow out of, and there should be, once they get to a certain age is when it would be concerning. For instance, in your toddler population, you might want to focus on those bone variations that they have. So oftentimes toddlers will have what we call knock-kneed and bow-legged, just the way they walk. They'll kind of have that waddling gait with the bow legs. As a toddler, normal. They're not going to be concerned with that. Once they hit 5 or 6 years old, yes, they're going to start to be concerned. So making sure you know those normal abnormalities, I guess you would say. And when you're doing a physical exam, another thing to keep in mind is the least amount of restraint possible is the best method. I've had children as young as 2 years old that I've started an IV on without being really held down, just reinforced her arm because I use that anticipatory guidance. Now again, it's not common, but it can be done. If you can have the child sit in the parent's lap, that is the best method for your younger children. But the least amount, don't just assume you need to go all in and hold them down, because that might not be the case. And you can actually make it worse because you're creating anxiety that maybe wasn't there until you went a little overboard with the restraining. So these are those growth charts I talked about. Generally, you don't see these paper formats anymore. They do electronic charting in a lot of the pediatricians' offices. So instead, you will see, you may get a printout as a parent where it shows, but it's similar layout. So this is kind of what the paper format used to be. There's 4 different ones. So you have one for boys and girls of each age range. So you have a smaller one for smaller children from birth to 3 years. And then you have one that goes from 2 to 20 years. And you see it's kind of on a bell curve, and it shows you where it should curve and then kind of taper off. So they should be within that 5th percentile line and that 95th percentile line with no huge changes. And their height percentiles should be somewhat close to their weight percentile. There shouldn't be drastic differences. So now we're going to talk about caring for the child as well as the family during hospitalization, and some things to take into account when you're caring for those children under this stressful situation. So one thing that's very important that I want you to know about is the stages of separation anxiety. Who can experience separation anxiety? What stages? Actually, every single developmental stage goes through separation anxiety, from infancy to adolescence. So separation anxiety starts around 9 months when they start having that stranger anxiety, separation anxiety from their parents. So they're still in that infancy stage. The one big key difference in separation anxiety is who they have anxiety regarding. So in your infant, your toddler, your preschool, and your school age, all of those groups have separation anxiety from their parents. In the adolescent stage, however, that separation anxiety is from their peers. So they're still having separation anxiety. It's just from a different group of people. So you want to make sure you're taking that into account when children are hospitalized, even ones that are hospitalized frequently, like when you have your patients with cystic fibrosis, they get admitted a lot, or patients who are receiving chemotherapy. Even though it's still routine for them, they still have that separation anxiety from their friends and feel isolated. They may start going through despair. So one important nursing intervention is make sure you're promoting those visits from their peers, letting that patient dress in their own clothes when you can, so that they can establish that sense of normalcy. So the 3 stages of separation anxiety: your protest phase, your despair phase, your detachment phase. So your protest phase is when you drop your kid off at daycare and they stand there and scream and cry. The picture here is an example of that protest phase. They throw a little fit about, being so upset that they're being left. That's that protest phase. So the next phase is the despair phase. They're not crying, but they're very sad about it. So this is when you drop them off at daycare and they're no longer sad, or they no longer cry, but they just go sit in the corner and sulk and look pitiful. That's that despair phase. getting to them a little more and more. So the concerning phase is the detachment phase. And detachment phase actually looks like they are adapting to their environment, but it is actually very maladaptive. So what happens in the detachment phase is where you drop them off at daycare, they don't even pay attention to you, or when you go to pick them up, they don't even care that you're coming to pick them up, and they're more interested in their daycare provider. So with the detachment phase, it looks like they're adapting and they're getting used to that environment, but really what they're doing is it's an ego defense mechanism where they are protecting themselves. So they will actually emotionally detach themselves from their parents. They will create essentially that border or that wall so that they are not going to get hurt by being not having that interaction with their parents. So they'll start having increased interactions with strangers. They'll seem withdrawn from their parents, or they'll just ignore their parents when they show up. They look happy, but can actually lead to long-term psychological problems if it continues in that phase. So some effects you may see on the child themselves when they are hospitalized. All children, I mean, this is adults too, some of the major causes of stress that they have. I just mentioned the separation. Pain is a stressor for everybody. And fear of body intrusion, especially in your toddlers and your preschoolers who have some knowledge, but they have extremely poor understanding of body boundaries. So they don't understand what you're doing a lot of times. So when you stick them with a needle, it's not just the fact that you stuck them with a needle and it hurts, but the fact that at that age with that imaginative thinking, they think all their insides are going to leak out because you just put a hole in them. That's why toddlers and preschoolers love Band-Aids, because they need to cover that hole. They have those poorly defined body boundaries. So some common things that you'll see related to stress in the child: regression. Regression is the most common ego defense mechanism you will see in the pediatric population. So what regression is where they're going back to previously learned experiences or previous ways of doing things. And what I mean by that is, for instance, maybe they start sucking their thumb again. Maybe a child who's potty trained is suddenly wetting the bed. They may start talking baby talk or decreasing their language. And that is the reason they do this, is they're going back to their comfort zone. That's like crawling in the bed with your blankie and being in your comfort zone. So they'll regress. Sometimes this can extend beyond hospitalization after they go home too. So that's important to have that anticipatory guidance with those parents and letting them know to keep an eye on it. But it is normal. Some other things that can happen related to these stressors, they may start having changes in their sleep patterns. Suddenly they're waking up with night terrors or nightmares, or they're having trouble going to sleep, and that can be a sign that that stress is really getting to them. They may suddenly start having fears they didn't have before, and all that can lay into it. So I said we were going to talk about the individual developmental stages and how they are related. So when we're talking about the hospitalized infant, this is from your newborn to your 12-month-old. Infants get frustrated too. They are, we think they just kind of go with the flow, but especially when you're talking about an older infant, they do have their routines, and those routines are going to be disrupted, and that can it can cause them stress as well. You'll see it in their vital signs. You'll see it in their respiratory effort. You'll see it in their ability to tolerate feedings they may not want to eat because of that stress. So one of the really important things about an infant, well, really with a lot of these groups, is to promote that parent at the bedside as much as you can. Most pediatric hospitals have very liberal visiting hours in the pediatric population, especially for parents, because you want to promote that bedside interaction as much as you can. This can really make a difference in the outcomes for those children. Another important thing with infants, and this also is something that applies to all of the developmental levels, is consistency in caregivers. So when I worked at MCV in the PEDS unit, we had what we call primary care nursing. So usually each patient would have a primary nurse, meaning every time that nurse worked, they were the ones caring for that patient. So they had that consistency of people caring for them, and it establishes that comfort. In this stage, they're in that trust versus mistrust stage of development. So again, they're learning how to trust people. They're learning how to trust that they're going to be taken care of. So that can create that stressor too when they are situated with changes in their environment, changes in their routine, changes in their structure. So then when we're talking about the hospitalized toddler, this is generally 12 months to about 3 years. This is when they're also developing that sense of trust. They have very magical thinking at this stage. You have big imaginations. They also take everything you say literally. So when you tell a toddler or a preschooler that you're going to take their blood pressure, they think you are actually taking something away from them. They may get upset and cry, not because they're worried about it hurting, but because they think you're taking something away from them. So you have to be very careful about what terminology you use with children and how you word things. The things we may use in the adult population may create additional stressors for them. So another thing they have is animism. Along with that magical thinking, they start developing that animism where everything is alive. So they talk to their teddy bear like it's alive. They give it like human types of personalities and stuff. You want to make sure you're very honest with them. Like I said, this goes across to every population or every developmental group, but this is important for them as well. When they don't trust you, they are going to show a lot of behavioral anxiety. And again, restraints may be needed, but use those as minimally as you can when you're needing to restrain them. And use restraints that are more comfortable. Like if you can, use a sheet to wrap them up like a burrito to restrain them instead of using the papoose or any other devices that may hold them down. Some methods you can use for this population to help with soothing and anxiety. You can use rocking, talking to them, singing, play. Remember, play is the universal language of children, and it can help them a lot. So then when we're talking about the preschooler, this is generally, again, it overlaps a little bit, 3 to 5, 3 to 4. This is that age where they start really developing that fear of bodily harm. They don't really understand the boundaries of their body. They don't understand what's going on with their body. They have that concrete thinking is starting to develop, but it's very immature. So they have a little bit of understanding, but they also have that magical thinking with it, so they take it way out of proportion. Again, if you tell them you're going to take their blood pressure, they're going to think you're taking something away from them. If you stick them with a needle, they're going to need that Band-Aid because they're going to think all their insides are going to come out. They should be encouraged to ask questions, and you can answer those on their developmental level. Make sure your explanations are, again, realistic. Be honest, just like with all the other ones. And then your school-age child. This is where they really start getting into that concrete operation stage. They can identify much more with what you're saying. That magical thinking starts to diminish a little bit, so they can understand what you mean by take a blood pressure, for instance. This is when they're getting the big part of a school-age child is when they're getting that industry versus inferiority thing. That's their stage. So these are ones that are always going to want to participate in their care. And if they don't get to participate or don't get to have a say, they're going to find a way to protest in various different ways. So for instance, if they state, all I'm going to eat is chicken nuggets, what do you think is the best way to approach that? The best way actually to approach that is to give them what they want. And I know normally you wouldn't promote just letting a kid have whatever they want, like a spoiled brat, but in the hospital setting, it's probably not just that they want just chicken nuggets. That's their way of having control over their own body. They're old enough to understand themselves as an individual person. So at that point, they need some kind of control over their individual person, and all that control is now being taken away from them. Everybody is making their decisions for them and poking them and prodding them and not giving them any choices. So if they want the chicken nuggets, give them the chicken nuggets. If they want to wear a certain outfit, let them wear the outfit. Let them have choices when they can. Don't give them options for choices when that option is not available. Like asking them, and I do this with my kids all the time, and I catch myself as soon as I say it. I'll ask my kids, "You ready to go to bed?" What do you think they tell me? They say, "Nope." And of course, at that point, I say, "Well, too bad, you're going to bed anyway." And then I gave them an option, but I wasn't really giving them an option. Instead, you should say, like, it's when you're talking about medication, for instance, you shouldn't ask a child, "Are you ready to take your medication?" Because they're going to tell you no. And when you tell them you got to take it anyway, well, you've just taken that choice away it seemed like you gave them. So instead, say, "It's time to take your medication. Would you like to take it in an oral syringe or a cup?" That's an option you can give them. "What would you like to drink after your medication?" Those are those options you can give, but don't give them options when you can't. And then the adolescent. Even adolescents have their own special needs that are different from adults. So they do have a little bit of more abstract thinking. They're getting into that so they can kind of have a adult comprehension of the information. But the way they manage their feelings is going to be a little bit different. Again, they're also going to have that loss of control experience. They're where they're trying to establish their social identity and their independence and all this stuff even further, and then you're completely taking that away from them. A lot of times adolescents do a lot better when they have a roommate that's of their age, because remember, they get that peer separation anxiety, so they need somebody of their similar age to communicate with and talk to and understand what they're going to. Another important piece is confidentiality. Confidentiality is huge in the adolescent patient. So sometimes, and you'll find a lot more and more pediatricians are having it where when adolescents are doing their annual physicals, they actually want to talk to them, on their own without their parents, because they need to start practicing and having that ability to talk without their parents being overseen by them. So the state laws for adolescents varies a little bit. In Virginia, once you're at the age of 14 years old, you can go in and get treatment without parent consent for certain conditions. So these are what we call emancipated conditions. So any kind of psychiatric or substance abuse. If an adolescent can walk into an ER and say, "I want to kill myself," and they can treat him without any kind of parent consent. Anything sexual related, pregnancy testing, STD testing, you can totally consent to that at the age of 14 in the state of Virginia without parent consent. And the kicker of it is we cannot tell the parents the results of those tests or what we are doing. So that gets to be at that age where we treat them as an adult. Again, it's an emancipated situation. They're treated as an adult in this situation. So, and I've had lots of parents get very mad. They'll call up billing, for instance, at KidMed and ask why a pregnancy test was done on their daughter. So when you're talking about those emancipated situations, like I was saying, you have where a parent would call back to billing saying, "Why is there a pregnancy test on my bill?" And you would explain you can't give them any information, and they would be irate that they have to pay for this test that they don't even know the results of or that it was done. Honestly, I see both sides. I'm a parent as well. I could see from the parent's perspective how frustrating that would be. You still feel like you have the right to know what's going on with your child. However, I also see it on the law side, because if you take that right away from those adolescents, all they're going to do is they're not going to get the health care they need. So instead of going to the doctor when they think they have an STD, they're going to hide it. And if they're pregnant, they're going to hide it. If they are feeling suicidal ideations, but they know that they don't want to discuss that with their parent or their parent's going to blow them off, they're going to hide it. And that's why that law is there, to make sure those children are getting the medical care that they need. Another important piece of that hospitalized adolescent is making sure that you're promoting not just honesty, but confidentiality. They need to understand that you're going to keep what you say between the two of you, but you also need to make it clear to them, I will keep what confidential what I can. For instance, you need to tell them if this is something I may need to tell somebody else. Like for instance, if somebody's been raped, they have to know, I have to discuss this with the police, for instance, or whatever the situation is. So hospitalization doesn't just affect the child, it affects the parents as well. So parents, they often have this sense of helplessness. They've been caring for this child and all of a sudden somebody else is caring for their child. So you'll see where they're often questioning skills of the staff. They're at, are you sure you're doing it right? They're over watching you. They often will show anger or yelling. This is that sense of just grieving and not having control. They're scared. They're often in a phase where they're going to blame themselves. They're going to be angry at themselves. So they need reassurance. They need you to tell them, you know, it's not your fault, and give them some of that anticipatory guidance. As far as siblings, the most common reactions are guilt, resentment, and jealousy, especially resentment and jealousy. When you're talking about a child with chronic conditions is where you really see this. The siblings feel like they're getting no attention from their parents because all that attention has been directed towards that sick child. So they'll have a lot of that anger and resentment. They may even have guilt too if they got in a fight with their brother or sister or something like that. So when we're prepping for admission, the length of time you prep a child for admission is going to be based on their developmental level. Again, everything we do is based on developmental level. So the older they are, the longer ahead of time you can tell them about things. Like if they're having surgery, a adolescent, you could tell them a couple weeks ahead of time, but a toddler, you probably don't want to tell them more than a day or two just because they'll build up that anxiety over time. So you want to, again, prevent or minimize separation, parental absence as much as you can, promoting those liberal contact hours or visiting hours, minimizing fear of injury, bodily injury, and a lot of that is going to come from that anticipatory guidance. Your child life specialist, most hospitals with a pediatrics area have what's called a child life specialist, and they are fantastic at knowing techniques for communicating with children as well as knowing how to bring their siblings into the hospital. So identification is very important. It's just as important in the children as it is for adults. One thing you might see, that top picture, and you'll see this when you go to the newborn nursery when you're doing L&D, is a security band. So what this band does is it will alarm if that child is taken outside of certain areas and there's alarms on the doors, the alarms will go off. So it's very important that those are checked to make sure they're on appropriately. You always see this in newborns, but you'll see it sometimes in older children as well. When they're there for cases of child abuse, for instance, they may put them on. I one time had a 15-year-old, he had been on the adult trauma unit after a gunshot, and he eloped from the hospital. So when the police got him and picked him up, they brought him back to the hospital, put him on the peds unit, and put that security band on him. So he could not leave at that point. But checking to make sure, one, it's there, and that it's on appropriately is very important. And then discharge planning. As you know, discharge begins on admission. You need to give them written as well as verbal instructions, and you need to validate their understanding of the information given. Remember that teach back and return demonstration are the best ways to determine if they truly understand the information that they were given. So make sure you're ensuring that understanding of the information they gave, and give as much anticipatory guidance as you can, because that can really help alleviate some of those fears.